Welcome to the funnel effect. I am genuinely excited for this deep dive today. We're really getting into an area where technology and anatomy meet with pretty high stakes involved. We're plunging into the state-of-the-art strategies for catheter ablation, specifically for ventricular tachycardia, or VT.
Right.
And not just any VT, but the kind that pops up late after someone's had a heart attack, a myocardial infarction. This is, well, it's one of the trickiest challenges in cardiac electrophysiology right now. Our mission here is to really unpack the electrical detective work. I mean, the sophisticated mapping needed to pinpoint and then hopefully destroy these tiny, complex electrical circuits causing these, life-threatening arrhythmias. And this whole discussion, it's grounded in a really comprehensive state-of-the-art review. It's titled, Mapping Strategies to Guide Ablation in Ischemic Heart Disease. We should definitely credit the authors for pulling this together. William G. Stevenson, Travis D. Richardson, Arvind N. Kanagasundram, and Harikrishna Tandri. It was published in JTC Clinical Electrophysiology just this year, 2024.
Yeah, that review does a fantastic job of crystallizing where we are. And it really highlights the fundamental challenge here. When we talk about VT that shows up, weeks, months, sometimes even years after an MI, the underlying cause is almost always the same thing: scar-related reentry.
Scar tissue. We usually think of that as just, well, inert, right, dead tissue. But here, it sounds like it's actively causing the problem. How does that post-MI scar actually create the conditions for reentry?
Well, it's because the scar itself is incredibly heterogeneous. It's not just a solid block. When heart muscle dies, those necrotic myocytes, they get replaced mostly by collagen, fibroblasts, that kind of fibrous matrix. But crucially, bundles of surviving heart muscle cells get tangled up, trapped within the scar tissue.
Ah, okay, so living cells mixed in with the scar.
Exactly. And that creates this really complex environment electrically. The signal, which normally zips across healthy muscle really fast and smooth, suddenly hits this scar zone, and it's forced into these winding, twisting, sometimes microscopic paths, like a zigzag course, as you said. This makes the conduction incredibly slow and very stop-start discontinuous. If that wavefront slows down enough as it crawls through the scar, it can pop out the other side, loop back around fixed barriers that dent scar itself, and re-enter the path it just left.
Creating a sustained loop.
That's the reentry circuit, a dangerous, self-perpetuating electrical loop.
So the complexity, the sort of messy 3D structure of the scar is the problem. The electricity is using the leftover muscle like a poorly maintained road.
That's a really good way to think about it. And the whole point of ablation, in theory, is simple. Find that road, specifically the worst section of it, and we'll blow it up, interrupt the track. We're hunting for that critical choke point, the narrowest part of the path. The review calls it the isthmus. That's the Achilles heel. If we can cut that channel, the VT stops.
But the authors really emphasize how varied these scars are. They're not all the same shape or structure.
Oh, not at all. These circuits are seriously complex, three-dimensional things. An isthmus could be tiny, short and wide. Or it could be centimeters long but less than a millimeter across, and location-wise. It could be right on the inner surface, the endocardium. It could be deep inside the heart wall, intramural. Or even on the outer surface, the epicardium. This variability is exactly why we need a whole toolkit of mapping strategies. One size definitely does not fit all.
Okay, that makes sense. And this leads us right into the main distinction the review makes. There are two really broad approaches, often used together. Let's start with the one that seems focused on stability first. Substrate mapping.
Right. Substrate mapping, that's the first big pillar. We do this while the patient's heart is stable, either in its normal sinus rhythm, or maybe we're pacing it steadily. We're essentially mapping the potential for trouble, looking for the electrical warning signs, areas of low voltage, signs of slow conduction that tell us, hey, the architecture for VT exists here, even if the VT isn't actually happening right then.
So you map the danger zones while things are calm?
Exactly. And this is usually the preferred starting point, especially for patients who are higher risk. Maybe they have really poor heart function, a low ejection fraction, or massive scars. Trying to deliberately trigger VT in those patients can be really risky, hemodynamically unstable. Substrate mapping lets us try and neutralize the hidden dangers while the patient is stable.
Like mapping the blueprint of a bomb without actually setting it off?
Okay.
And the second main strategy?
The second pillar is VT mapping, and this is where we map during the tachycardia itself. This is the real-time, high-def approach. It's definitely riskier, like we just said, but it's incredibly specific. You're literally tracking the live reentry wave, watching it circulate, trying to pinpoint that critical isthmus while it's active.
When would you choose this riskier approach?
It becomes necessary in certain situations. Like if the VT is just running constantly, we call that incessant VT, or if a previous attempt using substrate ablation didn't work, the VT came back. Or
Mm.
sometimes you just need that absolute precision. It's this constant balancing act, speed versus risk versus how precise you need to be.
That distinction, mapping the potential danger versus mapping the active fire, seems absolutely central. Let's dig deeper now into the structure we're trying to target. All right, let's talk circuit anatomy. The source uses this classic model, the figure-of-8 reentry circuit. Even if reality is messier, it helps visualize the key parts we need to find and ablate. Can you walk us through those components?
Absolutely. The figure-of-8 idea, it gives us the key landmarks on this electrical racetrack. The absolute most critical part is the isthmus, or the channel. Think of it as that narrow bridge of surviving connected muscle fibers squeezed between two impassable barriers of dense scar. Conduction here is slow, tortuous, and absolutely essential for the circuit.
The bottleneck.
Exactly, the bottleneck. Then you have the riverbanks, so to speak, the lines of block. These are areas of dense scar, true fibrosis, where the electrical signal just cannot pass. They define the edges of the isthmus, forcing the wavefront down that narrow channel.
Okay, so the wave gets through the narrow isthmus. Then what?
Right? It exits the isthmus, that's the exit point, and then it typically spreads out relatively quickly across the healthier surrounding muscle. This forms the larger loops of the figure-of-8. These loops eventually curve back around to the entrance of the isthmus, and the whole cycle starts again.
And you mentioned variability before. Where can this isthmus actually be located within the scar?
That's the tricky part. It's highly unpredictable. It might be smack in the middle of the scar, it could be right on the border where healthy tissue meets damaged tissue, or sometimes it can be a long channel that stretches right across the entire scar.
And the depth. That seems like a major headache.
It really is. The review stresses this constantly. The 3D nature of the scar is a huge challenge. If that critical isthmus pathway is buried deep within the heart wall, what we call an intramural component, our mapping catheter sitting on the inner surface, the endocardium, might be electrically quite far away.
So you might not even see it properly from the surface.
Exactly. And what's really deceptive is how these deep intramural circuits can sometimes behave electrically. They might exit onto the surface at just one tiny spot. So when you map it from the endocardium or epicardium, it might look like a simple focal VT, like it's starting from a single point. But in reality, it's the exit of a complex, deep re-entry loop. We always have to consider that the surface map might be hiding a deeper storm.
Okay, so before we even start deploying these mapping tools, there's some upfront planning. Let's talk workflow. How useful is pre-procedure imaging, like MRI or CT?
Pre-procedure imaging is definitely valuable, though maybe not strictly essential in every single case. MRI, particularly with that late gadolinium enhancement, LGE, it's excellent for showing where the scar is, how big it is, its overall shape. We can actually take those MRI images and import them directly into our 3D mapping systems in the lab.
Like a roadmap.
Sort of, yeah. The LGE highlights the dead fibrotic tissue. So the thinking is the viable channels, the potential isthmuses, must lie between these dense scar areas, or maybe along their edges. It gives you a predicted map, suggests where to really focus your initial voltage mapping.
Sounds very helpful. But then comes the moment of truth, often involving program stimulation, PS actually trying to induce the VT. Why take that risk up front?
Well, PS is really crucial for setting the stage. The upsides, the pros, are pretty significant. First, it confirms that yes, this patient's problem is scar-mediated VT. Sounds basic, but you need to confirm. Second, you capture the VT's fingerprint, its exact QRS morphology, how fast it is, the VT cycle length or VTCL. These become absolutely critical benchmarks later when you're doing things like pace mapping or entrainment mapping.
So you know exactly what you're fighting against.
Precisely. PS also helps distinguish this kind of scar VT from other possibilities, things like bundle branch reentry or VTs coming from the right ventricle. The review mentions it happens in up to 11% of these patients. You might miss those entirely without PS.
That's interesting. The review also brought up a subtle point about when to do PS. They suggest maybe doing it before the voltage mapping, which seems counterintuitive. Why?
Yeah, that's a really key practical point. It's about the physical effect of the mapping catheter itself. As you move the catheter around, pressing on the heart wall to get good electrical contact for voltage mapping, that mechanical pressure can sometimes actually compress or temporarily stun the critical isthmus pathways.
Oh, so mapping itself can make the VT harder to induce later.
Exactly. You could spend an hour doing detailed voltage mapping, then try PS, and suddenly the VT that you know the patient has is non-inducible. Now, you can't map it directly. You can't even confirm if your ablation worked based on inducibility. Doing PS first captures that baseline electrical state before you potentially alter it mechanically.
That makes a lot of sense. Okay, but let's not forget the downsides of PS, the risks, and maybe getting too much information.
Definitely. The cons are serious. First, safety. Inducing VT, especially fast VT in someone with a weak heart, can cause blood pressure to plummet, trigger ischemia, even lead to cardiac arrest. It's inherently risky. And then there's the complexity issue.
Oh.
Often you can induce multiple different VTs in the same patient, maybe 4 or 5 different QRS shapes, different speeds.
Right.
The really tough question then becomes, which of these inducible VTs are the ones actually causing the patient problems, the clinically relevant ones? Which ones match what their implanted defibrillator, ICD, has actually shocked them for?
If you can't always tell which induced VT is the clinical one, does that mean you have to try and ablate every single one you can induce?
Ideally, yes. The data suggests that achieving non-inducibility for all inducible VTs gives the patient the best chance of staying VT-free long-term. That's the goal. But it's not always possible or safe. If the patient becomes unstable or the procedure is dragging on, becoming very long and complex, the operator might have to make a judgment call. Maybe focus only on the VTs that look exactly like the ones stored in the patient's ICD. Or in really high-risk situations, they might even decide to skip VT induction altogether and rely entirely on substrate mapping. It's always this clinical balancing act driven by patient safety.
Okay, let's dive into that first main strategy, substrate mapping, finding those architectural danger zones while the heart's in a stable rhythm. And the absolute foundation for this, historically and currently, is voltage mapping.
That's right. It starts with mapping the electrical landscape using bipolar voltage. This measures the signal amplitude between 2 very closely spaced electrodes on the catheter tip. Generally, lower voltage means less healthy, viable heart muscle under the electrode, more scar, less signal. And the classic long-standing cutoff used to define dense scar tissue that's mostly non-viable is an amplitude of less than 1.5 millivolts, MV. This number comes from years of correlation studies. It's pretty specific for areas with severe fibrosis, like more than 75% of the wall thickness being scar.
Okay, 1.5 millivites sounds like a clear threshold. So why do the authors spend so much time explaining why this clear line isn't always so clear? What's this underestimation pitfall they talk about?
This is probably one of the most crucial insights, and it links directly back to that 3D scar problem we discussed. That 1.5 milliV cutoff, while specific for dense scar, significantly underestimates the total area that can actually support VT.
Yeah.
Here's why. Think about the heart wall layers. In many post-MI patients, the very inner layer, the endocardium, might actually have a thin, surviving rim of muscle cells, maybe just a millimeter or 2 thick.
Okay.
Our bipolar electrodes are sitting right on that endocardial surface. So even if most of the wall deeper down is dense scar, that thin surviving rim right under the electrodes can generate a relatively normal-looking voltage, often above that 1.5 milliV threshold.
Wow. So the surface reading can basically lie to you about what's underneath.
Precisely. The bipolar signal is very localized. It doesn't see deep into the wall effectively. The studies comparing voltage maps to cardiac MRI are really striking. They found areas where MRI showed significant scar, maybe 25% of the wall thickness was scar, according to the LGE signal, but the median bipolar voltage on the surface was still 2.2 millivolts, way above the 1.5 millivolt cutoff. If you only ablate areas below 1.5 millivolt, you could be leaving behind critical parts of the reentry circuit hidden deeper in the wall.
That's a huge deal. So if bipolar voltage has this nearsightedness, it makes sense we'd need a tool with a wider view. That brings in unipolar voltage mapping. How does that help see the hidden scar?
Unipolar mapping uses one electrode on the catheter and a distant reference point, like a patch on the patient's back. This gives it a much broader perspective, a wider field of view. It samples electrical activity from a larger volume of tissue, including deeper layers.
So it can detect scar even if the surface looks okay on bipolar.
Exactly. If you have an area with okay bipolar voltage, say above 1.5 milliV, but the unipolar voltage in that same spot is abnormally low, that's a big red flag. It strongly suggests there's significant scar deeper down intramural or maybe even epicardial scar lurking beneath that preserved endocardial rim. This border zone area, sometimes called the penumbra, is often where the most critical parts of the VT circuit are actually located. Unipolar mapping helps us paint a more complete transmural picture of the damage.
Okay. And within these scarred areas, you sometimes find regions with extremely low voltage, like below 0.5 millivolt, often called dense scar. Can we just assume that tissue is completely dead and ignore it?
No, and the review is very clear on this. Calling it dense scar can be misleading. Yes, these areas often correlate with the thinnest parts of the heart wall. But even in these very low voltage zones, down to zero point 0.1 milliV sometimes, if you try to pace there with the catheter, you can often still capture the muscle.
Meaning there are still living cells there.
Yes. It proves there are still some surviving myocytes present, even if they're sparse. And if there are living cells, there's potential substrate for VT. It's rarely truly electrically inert. That's why these ultra-low voltage areas often still need to be mapped and potentially included in the ablation.
This whole uncertainty around the voltage cutoffs and the hidden scar, it led some groups to try a more, well, aggressive approach: scar homogenization. Instead of meticulously hunting for one tiny path, why not just try to make the whole abnormal area electrically uniform?
That's exactly the philosophy, pioneered by groups like Dial-B and others. The idea behind homogenization is, let's target the entire low voltage area, everything below 1.5 milliV, and maybe even extend that to include any areas with weird-looking electrical signals, regardless of voltage. The goal is basically to create one large, contiguous, non-conducting block of ablated tissue. Turn that heterogeneous, dangerous landscape into a uniform, electrically silent zone where VT simply can't propagate.
A sort of scorched earth policy for the scar zone? How well does that work?
The results can be pretty impressive, actually. Studies have shown good outcomes, with some reporting up to, say, 81% of patients being VT-free after this kind of extensive endocardial homogenization. What's really important, though, is the willingness to go epicardial map and ablate on the outside of the heart if needed. One study showed that even after extensive endocardial ablation, if VT was still inducible, adding epicardial ablation significantly improved outcomes further. It really underscores that for big scars, you often need to tackle the substrate from both inside and out to be truly comprehensive and address that 3D structure.
Okay, so voltage gives us the broad geography, but we need more specific landmarks within that territory. Let's talk about specific electrical signals. Late potentials, LPs, and fractionation.
Right. LPs are kind of the classic sign of slow conduction during stable rhythm. These are electrical signals, little wiggles on the EGM tracing, that occur after the main QRS complex is completely finished, during the time when the ventricles should be electrically quiet.
Late signals, suggesting something is lagging behind.
Exactly. They represent electrical energy that's still slowly crawling through parts of the scar after the rest of the ventricle has already recovered.
They sound like a prime target then. If you get rid of the late potentials, does that mean you've fixed the slow conduction?
Getting rid of LPs is definitely a good sign. It's a strong predictor of success. One study by Silberbauer, for example, found much lower VT recurrence, around 16%, if they managed to abolish all the LPs, compared to nearly 50% recurrence if LPs persisted after ablation.
That's a big difference.
It is. But LPs have a significant limitation: the bystander issue.
Meaning they're not specific enough?
Precisely. LPs are everywhere in scar tissue. Yes, you'll definitely find them within the critical isthmus channel itself, but you'll also find them in adjacent areas of scar that are not part of the actual circuit. They're just innocent bystanders, electrically speaking. So you could spend a lot of time ablating a site just because it has an LP, but if that site isn't actually part of the critical pathway, the VT will continue. This lack of specificity pushed researchers to look for more distinct EGM features.
And that brings us to fractionation, looking for more complex signal shapes.
Exactly. Researchers like Andreu started focusing on highly fractionated electrograms, EGMs. These are signals that look really messy. Multiple sharp, spiky components, often following a smoother, rounded initial signal which might be far-field noise. The theory is that these complex high-frequency spikes represent the electrical wavefront breaking up or colliding as it enters or exits the narrow confines of a channel within the scar.
So the shape suggests proximity to an entrance or exit.
That's the idea. Targeting these specific multi-component signals, a strategy sometimes called dechanneling, aims to be more specific than just targeting any LP. The hope is to hit the crucial transition points, the doorways into and out of the isthmus. It's shown some success, allowing ablation of many inducible VTs in studies.
Okay, we've covered static markers, voltage, resting EGMs. Now we shift to something more dynamic: functional mapping. This involves actively provoking the tissue to reveal hidden problems. Why is stressing the circuit like this so usable?
It's useful because the heart's normal rhythm, sinus rhythm, can actually hide the true electrical behavior within the scar. Imagine those surviving muscle bundles within the scar. In sinus rhythm, they might all get activated more or less together, but they might have subtle differences in how quickly they conduct or how long they take to recover their refractory periods. By introducing a premature stimulus, an early beat, often called an S2, or by pacing rapidly, we stress the system. We exploit those subtle differences. This stress dramatically magnifies the timing differences between adjacent bundles. Latent slow pathways suddenly become apparent, signals might appear that weren't there before, or existing signals get significantly delayed. It unmasks hidden vulnerabilities.
So what specific signals pop out during functional mapping? What are we looking for?
There are a few key markers. One big category is evoked delayed potentials, EDPs. These are signals that literally appear, or get much later, only in response to that premature beat. They weren't obvious in the baseline rhythm. You also hear terms like local abnormal ventricular activity, LAVA, or decrement evoked potentials, DPP. These are all variations on the theme of abnormal signals revealed by provocative pacing.
And thinking back to that problem of underestimating scar with voltage mapping, is there a functional marker that specifically addresses that?
Yes, absolutely. That's hidden slow conduction, HSC. These are essentially EDPs, those functionally revealed delayed potentials, but they're found in areas where the bipolar voltage looks relatively okay, maybe between 1.5 and 2.3 milliV. This is precisely that hidden intramural or transmural scar that the surface voltage map missed. Functional mapping forces these hidden channels to declare themselves by showing extreme slowing or delay when stressed.
That seems incredibly powerful. How specific are these functional markers for the actual VT circuit compared to just finding LPs?
They're generally considered much more specific for the VT isthmus than LPs alone. Studies have shown pretty good sensitivity, sometimes up to 90%. One group, Martin and colleagues, found that essentially all the reentry circuit isthmuses they identified had these functional potentials associated with them. And targeting these sites works. It improves outcomes, especially in patients who might have smaller, more scattered areas of scar. Deriva's group showed that if they targeted EDPs as the very first step in the procedure, they could eliminate all inducible VT in about 2/3 of their patients. That really highlights functional mapping not just as an add-on, but potentially as a primary, highly effective strategy.
This focus on slow conduction naturally leads to the next technique, which uses high-density mapping to visualize these slow zones directly. Isochronal late activation maps, ILAMs.
Right. ILAMs combine high-resolution mapping with precise timing analysis. Modern systems use catheters with many electrodes, allowing us to record signals from hundreds, even thousands of points very quickly. For an ILAM, we specifically annotate the time of the latest part of the electrical signal, the bipolar electrogram, at each point during stable rhythm. This builds up a detailed map showing exactly when each little bit of tissue activated.
Okay, so you have a map of activation times. How do you use that to find the slow conduction zones, the potential isthmuses?
You look for areas of isochronal crowding. An isochrone is just a line connecting all the points that activated at the same time. Think of it like contour lines on a topographic map. If the electrical wave is moving quickly across the tissue, the isochrones representing sequential time points will be spaced far apart. But if the wave hits a zone of very slow conduction, it crawls. And those isochrones get packed tightly together, they become crowded.
Like a traffic jam for the electrical signal.
It's exactly like a traffic jam. The clinical definition of significant crowding often involves seeing, say, more than 4 distinct isochrones within a 1 centimeter area. This density corresponds to a calculated conduction velocity of less than 25 centimeters, which is extremely slow for heart tissue. These crowded zones are highly likely to represent the path of a critical isthmus.
That sounds very direct. Measuring the slowness itself, the correlation must be strong.
It is very strong. One study by Aziz defined these deceleration zones slightly differently, 3 or more isochrones within 1 centimeter. They then went on to map the actual VTs using the gold standard technique, entrainment mapping. They found that every single one of the confirmed VT isthmus sites was located precisely within one of these deceleration zones identified on the ILAM map. It really highlights the specificity of finding these crowded areas.
Interesting. You mentioned earlier that the extent of the slow zone you map can depend on where you pace the heart from. Why is pacing from different spots important for ILAMs?
Yeah, that's key. Think of the scar as a complex, rocky landscape. The path the electrical wavefront takes through it and where it slows down the most depends on the direction it approaches from.
Okay.
If you only pace from one spot, say the right ventricle, the wave hits the scar from one angle, revealing certain slow pathways. But if you then pace from a different spot, like the left ventricle, the wave hits the scar from a different angle and might reveal different slow conduction zones or make the previously seen ones look larger or smaller. So by pacing from multiple sites, typically at least one in the RV and one in the LV, you interrogate the scar from different directions. This increases the sensitivity of the ILAM technique, making sure you uncover all the potential slow zones that could possibly host a VT isthmus.
All right, one more substrate mapping technique to cover.
Yeah.
The classic pace mapping. How do we use pacing to find the exit point of the reentry circuit?
Pace mapping is conceptually quite elegant. The idea relies on the fact that the overall shape of the QRS complex during VT is mostly determined by how the electrical wave spreads through the healthy heart muscle after it leaves the scar. So, if you place your catheter right at the exit site of the reentry circuit's isthmus and pace from there, the way the activation spreads out into the healthy ventricle should be identical to how it spreads during the actual VT. Therefore, the PACE QRS morphology on the ECG should look like a perfect match to the clinical VT morphology.
A perfect match tells you you're at the exit. But how do you know you're pacing from within the slow isthmus itself, and not just from nearby healthy tissue that happens to activate at the right time?
That's where the stimulus to QRS delay, SQRS delay, comes in. This is crucial. When you pace directly from the isthmus, the electrical impulse you deliver first has to travel through that slow, winding pathway within the scar before it can emerge and activate the rest of the ventricle to generate the QRS. The SQRS delay measures that transit time through the scar. The review notes that delays longer than 40 milliseconds are pretty common when pacing from within an isthmus. So, finding a perfect QR match combined with a significant SQRS delay is very strong evidence that your pacing site is indeed the exit of a reentry isthmus. It acts as a surrogate marker for the isthmus itself.
That makes sense. And conversely, what about areas where you try to taste but you just can't capture the muscle, even at high energy? The unexcitable scar, does that tell us anything useful?
It does. These are areas where the pacing threshold is really high, typically defined as needing more than 10 milliamps of energy at a 2 millisecond pulse width to get the muscle to respond. These spots represent truly dense fibrotic scar. While these areas are electrically dead, they act as fixed boundaries. Identifying these unexcitable zones helps define the borders of the potential channels. And sometimes, a strategy involves creating ablation lines that connect these unexcitable areas, essentially walling off or compartmentalizing the remaining viable tissue within the scar. This can effectively interrupt certain VT circuits by blocking the channels between these dead zones.
Okay, let's shift gears to strategy B mapping during the actual ventricular tachycardia. The high-risk, high-reward approach. It sounds intense. When does the team decide, okay, we need to map this live?
Yeah, the decision to map during VT isn't taken lightly. It's usually driven by necessity, often when substrate mapping hasn't been enough. The review points to three main scenarios. First, if the VT is incessant, meaning it just keeps starting up again, or it's running continuously during the procedure, making stable mapping impossible. Second, if the patient has already had a prior substrate ablation attempt that failed. The VT came back, suggesting the firm approach missed something critical, and now you need the precision of live mapping. And third, sometimes the suspected origin of the VT is in a really high-risk location, maybe very close to the heart's normal conduction system, the His bundle, or near a major coronary artery. In those cases, you need absolute certainty about the target before you ablate, which often means mapping during VT.
The risks seem obvious, particularly keeping the patient stable hemodynamically.
Absolutely, that's the number one challenge. Many VTs, especially faster ones, cause a significant drop in blood pressure. This severely limits how much time you have to map before the patient becomes critically unstable. Operators might use rapid drug infusions, things like pressors or inotropes, just to try and maintain blood pressure for a few crucial minutes of mapping. In really severe cases, they might even need mechanical hemodynamic support, like an Impella pump inserted into the ventricle.
Wow.
But the source rightly points out that while sometimes necessary, using these pumps isn't without risk either. It increases the chance of vascular complications. It just underscores how high-stakes mapping during VT can be.
Assuming you can keep the patient stable enough, let's talk about the first technique, activation mapping, trying to follow the wavefront in real time. How do the mapping systems cope with the speed and the messy signals in scar tissue?
Modern systems are incredibly fast, often using multi-electrode catheters that can record from dozens or even hundreds of sites simultaneously. This allows for rapid data acquisition. But even with great technology, you hit the timing challenge. Remember how we talked about those fractionated, messy electrograms in scar tissue? During VT, they can be even more complex. It becomes extremely difficult to determine for each recording site which specific deflection on that messy signal represents the true local activation time. The first spike, the biggest spike. the latest one.
And picking the wrong one messes up the whole map.
Completely. If you consistently misidentify the local activation time, the resulting activation map will look chaotic, maybe showing multiple simultaneous wavefronts or patterns that don't make physiological sense. It won't show that clear circulating pattern you're looking for.
Okay, so if you manage to annotate the timing correctly and the map looks plausible, what's the key visual feature that tells you you're likely looking at the isthmus itself?
You look for diastolic activation. Here's the logic. The main mass of the ventricles activates very rapidly during the QRS complex on the surface, ECG. That's systole. But the re-entry circuit, especially the slow-conducting isthmus, has to be activating before that main ventricular activation begins, during the electrical quiet period, diastole. So on the activation map, finding areas where the recorded electrograms occur significantly before the onset of the QRS complex is a strong indicator that you're mapping within the isthmus. The activation of the faster outer loops of the circuit usually happens during the QRS itself. Tracking that sequence, diastolic activation flowing into systolic activation, helps visualize the circulating wavefront.
Activation mapping suggests where the circuit is, but the gold standard for proving a specific site is part of that circuit is entrainment mapping. The pacing proof, you called it. Can you break down how that works?
Right, entrainment is incredibly powerful for confirming causality. The basic idea is this. You pace the heart from your catheter tip at a rate slightly faster than the ongoing VT. Let's say the VT cycle length, VPCL, is 400 milliseconds. You might pace at 380 milliseconds. If your catheter tip is truly located within the reentry circuit, your faster pacing will temporarily take over or capture the circuit. You're essentially speeding up the merry-go-round. When you stop pacing, the circuit immediately snaps back to its original speed, the native VTCL. This proves your pacing site was interacting directly with the circuit.
Okay, so capturing it proves involvement, but how do you measure that interaction precisely? You mentioned the post-pacing interval, PPI.
Correct. The PPI is the key measurement. It's the time interval from your last pacing stimulus until the next naturally occurring electrical signal, electrogram, recorded at that same pacing site once the VT resumes its own rhythm. Here's the critical part. If you are pacing from inside the reentry circuit isthmus, the electrical wave you initiate travels around the fixed path of the circuit and returns to your pacing site. The time it takes for that round trip, the PPI, will be almost exactly equal to the natural cycle length of the VT, VTCL. So PPI VTCL.
And if you're pacing from outside the circuit?
If you're pacing from a bystander site somewhere remote from the actual circuit, your pacing impulse has to travel to the circuit, enter it, go all the way around, exit, and then travel back to your pacing site. That extra travel time makes the PPI significantly longer than the VTCL. That tells you you're not in the critical path.
Okay, so PPI matching VTCL gets you in the circuit. But how do you pinpoint the most critical part, the narrow isthmus itself, and not just some outer loop or entrance area?
That requires finding the absolute hallmark of isthmus pacing, entrainment with concealed fusion, ECF. This is where things get really specific. ECF means two conditions are met simultaneously during that overdrive pacing. First, the QRS morphology on the surface ECG looks identical to the QRS morphology during the native VT. This is the concealed fusion. It means your pacing is entering the circuit and exiting through the normal pathway, activating the rest of the ventricle in the exact same sequence as the VT does naturally. There's no distortion of the QRS shape. Second, the timing has to be right. The interval from your pacing stimulus to the start of the QRS complex, SQRS, must be the same as the interval from the local electrogram at your site to the start of the QRS during the native VT. This confirms your pacing is activating the local tissue at precisely the right moment in the cycle.
That sounds incredibly precise. Does that SQRS interval also give you information about where you are along the isthmus channel?
It absolutely does. It's like a GPS within the isthmus. Remember, the SQRS interval is the time it takes for your paced beat to travel from your catheter tip through the remainder of the isthmus and finally exit to start depolarizing the wider ventricle. So a short SQRS interval, the review suggests, maybe less than 30% of the VTCL means you're pacing very close to the exit of the isthmus. The travel time to get out is minimal. Conversely, as you pull the catheter back along the isthmus towards the entrance, the SQRS interval gets progressively longer. A long SQRS tells you you're pacing from a more proximal site, near the isthmus entrance, with a longer journey required to reach the exit. Mapping this SQRS gradient helps define the whole channel.
It sounds almost foolproof when you find ECF, but the review mentions pitfalls. What can go wrong with entrainment?
Several things. First, technically you have to pace gently. Use the lowest energy output that reliably captures, usually starting low, maybe 10 millA, And you need to time the pacing carefully, often starting in late diastole. Pacing too aggressively can actually terminate the VT, which sounds good, but then you lose your chance to map it completely. Or it could accelerate the VT into something faster and more dangerous. The second major pitfall is misinterpreting the signals, especially dealing with far-field potentials. Remember those messy EGMs. Your catheter might be sitting near the isthmus, but also recording a large signal from a big chunk of healthy muscle further away. If you mistakenly use that far-field signal to measure your PPI, it can make the PPI look artificially long, fooling you into thinking you're outside the circuit when you're actually very close.
Ah.
And there's also the tricky issue of bystander pathways. Sometimes you can get perfect ECF from a site that's in a slow conduction channel connected to the main VT isthmus, but not actually essential for it. Ablating that bystander might not stop the VT. You still need to find the site within the true isthmus that gives you the best combination, PPI matching VTCL, concealed fusion, and ideally mapping the shortest SQRS, the exit, or the full SQRS gradient.
Okay, lots to keep track of. Finally, let's talk about knowing you've hit the jackpot during the procedure. What are the signs, even before the ablation lesion is fully formed, that your catheter is right on the money, targeting the critical isthmus?
There are 3 really strong positive signs described in the review that give you high confidence you're in the right spot. First is pacing termination. If during your entrainment pacing, the VT certainly stops, but importantly, it stops without you globally capturing the entire ventricle, meaning your pacing didn't just overwhelm the whole heart, that's a very good sign. It suggests your pacing disrupted the delicate balance within the critical circuit itself. Second is mechanical interruption. Sometimes just the physical pressure of the catheter tip against the endocardium can terminate the VT. If this happens cleanly, the VT stops without triggering a burst of extra beats or chaos, ventricular ectopi. It strongly suggests your catheter is physically bumping or compressing the fragile critical fibers of the isthmus.
It's like blocking the road just by parking the car there?
Exactly. And the ultimate confirmation, of course, comes during the ablation itself. That's ablation termination. If, when you actually apply the radiofrequency energy, the VT terminates abruptly, and again, crucially, this termination isn't immediately followed by irritable ectopi, that is considered the most compelling evidence that you've successfully targeted and destroyed the critical isthmus site. Clinically, this finding correlates very highly with long-term freedom from recurrence of that specific VT.
All right, we've covered a huge amount of ground. Strategy A, mapping the staple substrate, looking for potential danger zones with voltage, LPs, functional mapping, ILAMs, pace mapping. And strategy B, mapping the live VT circuit with activation and entrainment mapping. The review makes it clear that the state-of-the-art really involves blending these approaches, right?
Absolutely. I think that's the key takeaway. There's no single magic bullet marker. The evidence clearly shows that these different substrate mapping techniques, low voltage, LPs, EDPs, ILAMs, they often identify slightly different, though frequently overlapping, regions of the scar.
So the substrate itself is complex and needs multiple tools to fully characterize it.
Exactly. It tells us the underlying arrhythmogenic substrate is just too diverse, too heterogeneous, to be perfectly captured by any one measurement alone.
And given that we don't have, large head-to-head randomized trials comparing, say, a pure scar homogenization strategy versus a purely functional mapping strategy, what's the practical approach most clinicians take today? How do they synthesize this?
The current approach is generally pragmatic and adaptive, often tailored to the specific patient's scar characteristics. For patients with really large, extensive scars, the strategy often involves a combination. They might start with scar homogenization of the very dense, low-voltage core area, zero 0.5 milliV, maybe 1.5 milliV, to sort of debulk the substrate. But then they'll layer on more specific techniques targeting those functional potentials like EDPs or HSC, using pace mapping to find exits, maybe using ILAMs to really zero in on the critical conducting channels within or around that homogenized area.
So for the big scars, it's like clearing the forest and paving over the specific dangerous trails.
That's a pretty good analogy, yeah. You simplify the overall landscape by ablating the really bad stuff, and then you use the more precise tools to find and eliminate the specific pathways that are still viable and dangerous. On the other hand, for patients with smaller, maybe more patchy scars, perhaps with better overall heart function, the approach might be a bit different. They might start by just ablating the entire small, low-voltage zone. Then they might rely more heavily on functional mapping, EDPs, LAVs, to find any remaining critical slow conduction sites, often located in the border zones around that main scar, that need very precise ablation.
And the results from these combined approaches look pretty good, with success rates reported in the range of 64% to 85% freedom from VT at 1 year.
Yes, those numbers reflect the progress made by integrating these diverse tools. It really speaks to the field's evolution, combining sophisticated electrical mapping, anatomical understanding from imaging, and advanced catheter technology to build this comprehensive 3D picture of the arrhythmogenic substrate. The ultimate goal, really, is to move beyond just painting a voltage map and towards being able to functionally interrogate and understand every potential conducting pathway within that scar, whether the VT is active at that moment or not.
That ambition to map every pathway brings us right back to that fundamental challenge we started with, and it sets up our final provocative thought for you, the listener.
Right. The persistent elephant in the room, as the review highlights repeatedly, is the intramural substrate. We know that many, maybe even most of these critical VT isthmuses are not right on the surface. They're buried deep inside the heart wall. And we also know they can connect to the endocardial or epicardial surface at very discrete points, making them look deceptively simple, like a focal source, when mapped from the surface.
So, if the critical pathway is deep, and our standard ablation catheters deliver energy that only penetrates maybe 3-5 millimeters, we might not be able to effectively reach and destroy that deep isthmus, even if we know where its entrance or exit is.
That's the core problem. You can ablate the entrance, you can ablate the exit, but if the critical segment is 6 or 7 millimeters deep, standard RF ablation from the surface might just not be sufficient to render it non-conductive. So the final thought is this. What are the real clinical implications of this persistent limitation? How does the ongoing challenge of effectively targeting these deep intramural circuits drive the next wave of research and innovation? We clearly need better integration of high-resolution imaging during the procedure to guide us to these deep targets. But perhaps even more critically, we need new ways to deliver ablative energy deeper into the tissue. Maybe more focused energy sources, non-contact ablation methods, or novel approaches to achieve truly transmural lesions reliably. Tackling the intramural isthmus remains the key frontier in ischemic VT ablation.
A really important challenge for the future of this field. That was an incredibly thorough, deep dive into the mapping strategies guiding VT ablation today. Really fascinating stuff. Thank you for watching The Funnel Effect.